Hello, my name is Pauline and I'm a researcher in the New Roles in Mental Health Research Project team. And today I'm going to explain what our research has found so far. So ultimately, our project aims to generate knowledge to help NHS mental health services work better. New roles are being introduced in mental health services to help with the staffing crisis by increasing capacity and taking pressure off existing staff. New roles can also help bring in people who are new to care, create new career pathways, and offer development opportunities to staff. New roles can also bring in new skills and diversity to the workforce. However, introducing new roles can be disruptive and have unintended consequences for existing teams where the new role is placed. For example, introducing a new role could increase complexity or create more work for the existing staff. So it's really important to understand the dynamic effects of this type of reorganisation to ensure that new roles can benefit service users and both the new and existing workforce and avoid negative impacts. So this project will help us understand how mental health services can best implement new roles to maximise benefits for staff, service users and organisations. Our research has 4 phases, and today I'm going to focus on what we've learned so far in phases 1 and 2. So phase 1 has involved a mapping exercise to discover what new roles have been implemented so far in mental health services. In phase 1, we completed online interviews with heads of HR or workforce leads in English mental health trusts. We asked about how and where the new roles had been deployed and the rationale for and experiences of implementing these roles. 31 of 51 mental health trusts responded to us, and these 31 responses were made up of 26 interviews, 2 completed questionnaires, and then detailed information from 3 of our partner mental health trusts. And as you can see there, the response rate varied, but we received responses from all regions across England, which was very good. In phase 2 of the project, we held a number of stakeholder reflection groups to consider these phase 1 findings. And the reflection groups included experts in new roles in mental health who could help us model what's happening out there in practice. So our experts for the groups included policymakers, mental health trust leaders, professional leads, and then representatives from other relevant bodies. In summary, almost 80 new roles were reported across the 31 trusts. However, what was considered to be a new role varied really significantly between the trusts. We found that data available on new roles was generally of poor quality, and that was often due to erratic or inconsistent coding of new roles in the electronic staff record. It was also quite difficult for us to locate anyone in a trust with full oversight of new roles there, who could provide really reliable information without lots of extra work for them. And overall, we found a huge amount of uncertainty across the sector about what these new roles did and how they could complement existing teams and staff. One of the main things the team was interested in looking at was how staffing new roles change the skill mix in mental health services. So to implement a new role, it's really important to understand this. So skill mix can be described in different ways as the mix of different staff in a team, the range of competencies possessed by each staff member in the team, or the ratio of senior to junior staff in the team. And skill mix has been described previously by other researchers, including Nelson and colleagues, Sibbald and colleagues, and Nancaro and Borthwick. Introducing new roles into a team or service can change the skill mix in different ways. And we've organised our findings according to 5 different types of skill mix change. And these 5 categories have been adapted from previous research. Delegation involves the tasks or responsibilities of staff in existing roles being delegated to staff in more junior positions. Horizontal substitution is when existing tasks and responsibilities are reallocated to other roles at similar levels of seniority, but in a different discipline. Specialisation is where a role is created or changed to focus in on a particular area within its own discipline. Diversification is when a role expands to include broader tasks and responsibilities within its own discipline. And finally, innovation is where a role is created to do something entirely new that wasn't done previously within a service. So let's examine some of the examples of the new roles we found and how they might map onto this skills mix framework. The new role of Clinical Associate in Psychology, or CAP, was a clear example of delegation. So briefly, the CAP is a role that provides interventions to a specific population, so for example, children and young people or adults, based on psychological assessment of a person's needs, and they work with people with long-standing and complex mental health issues. So CAPs were described by key informants in our research as examples of delegation, as they don't have the same level of training or autonomy as clinical psychologists, but they are capable of doing a subset of that role under supervision. It was suggested by one respondent that CAPs feel like they could be a work engine in terms of delivering a bulk of therapies, a bulk of group work with people here on the ground in the absence of psychologists. An example of horizontal substitution observed in our research so far is the multi-professional approved clinician, or MPAC. An approved clinician is a mental health professional who's approved by the government to make decisions under the Mental Health Act. And until quite recently, this role was delivered only by approved psychiatrists and social workers. But it's now open to psychologists, nurses, and allied health professionals as well. So MPACs in our study were described by key informants as examples of horizontal substitution, where they undertake the roles and the responsibilities that psychiatrists might have historically done. So, for example, leading a service or taking on the role of responsible clinician. For example, during our reflection groups, a participant commented that in their trust, MPACs are now taking out what would probably have been the use of locum psychiatrists in our assertive outreach service. Advanced practitioners, or APs, come from a range of professional backgrounds such as nursing, pharmacy, paramedic, and occupational therapy. They are healthcare professionals educated to master's level, and they've developed the skills and knowledge to allow them to take on specialist roles caring for patients. So in the study, APs were described by key informants as examples of specialisation because they were employed in mental health services to draw on their professional expertise, working at a very advanced level with their own specialism. One trust commented that APs are aligned to specific pathways in our trust. For example, severe multiple disadvantage, where they really add value because they understand the deprivation and need across our area. Interestingly, no examples of diversification through new roles in mental health services have been encountered in our study so far. An example of innovation observed is the creation of the peer support worker, or PSW, role. PSWs use lived experience to support people and their families receiving mental health services, forming part of service users' care teams and supporting their well-being and recovery. PSWs were described by key informants as examples of innovation in mental health services, as their specific expertise was not previously present in mental health teams. One informant explained that PSWs are not taking the place of healthcare support workers or other registered clinicians. They are there to work alongside patients and be a befriender or somebody who can appreciate and understand. When it came to the rationale for new roles, most roles were described as a form of delegation. Others were described as involving horizontal substitution, specialisation and innovation, but as we've already mentioned, no diversification was reported. We also noted that a new role might span more than one of these categories, representing more than one type of change, and they may evolve and shift over time. And there might be a difference between planned changes and actual changes in practice, with roles being used in different ways from what was originally intended. Interestingly, there seems to be a tendency to fragment work and move to more generic role titles. Thinking about skill mix change in these ways could help leaders and staff to understand and communicate the kind of change each new role is meant to deliver. It can help them review how roles evolve to ensure that they still fulfill their purpose and identify opportunities to learn across roles. But how can we use what we've found to support the integration of new roles in practice? Well, so far, our research has told us some of the important practical internal enablers to smooth implementation. Participants described to us a range of things that trusts and teams could do to ensure that new roles were effectively introduced and could integrate into teams to best improve care. These internal enablers include having a strategic approach. There were perceived benefits to a coherence in vision, communication, and a top-down approach, but there were challenges in balancing consistency and flexibility. Clear communication about what a role can and can't do was seen as an enabler, explaining where the role fits and the benefits it can bring. Trusts identified a need for open conversations with staff where candid concerns could be voiced about the limits of and the problems around implementing new roles. The presence of a clinical champion was emphasised as a key enabler, especially at the start of the implementation process. Sharing examples of successful implementation could make a major difference to how roles were received. Structures to support workforce planning were key, for example, establishing new roles governance or advisory groups, new roles lead posts, and other governance structures. The capacity for supervision and informal mentoring could also make the difference between successful and less successful implementation. Finally, a willingness to change was key. For example, openness to repurposing vacancies, although professional protectionism may be present as a barrier here. The direct feedback we got from NHS trusts shows us the reality of internal enablers working in practice. And here's a taste of what we heard. One trust commented that people are so busy, we have to think about how to pitch the roles to them and really give them headspace to try and get their heads around it. Another noted that it's all about the balance, and her tip would be that you don't want to try and control everything, but you do need a degree of order. A further trust reflected that I think as we've become kind of more mature in our approach to embedding things, we're taking a lot longer in planning. Participants also suggested a number of things which could be done at a regional or national level to support the introduction of new roles. These external forms of support recommended include national guidance or frameworks. There was a desire for off-the-shelf packages for new roles, including job descriptions, competency frameworks, standard operating procedures, career pathways, and guidance on pay and banding, governance, and regulation. Opportunities to share learning was another enabler. Trusts wanted and needed to learn from each other, for example, via regional forums, sharing job descriptions, training agreements, best practice, policies, and sharing evidence from role evaluations. Good communication was said to be essential, and this is particularly important between the national and the regional levels. So, for example, between NHS England and the integrated care boards, and onwards to local level, for example, primary care networks and the London boroughs. Forewarning was said to be absolutely vital, and this means having sufficient time to effectively introduce and socialise new roles, communicate the case for the roles, and promote their benefits. We heard that, for example, mental health and wellbeing practitioners did not land well due to the tight turnaround set by NHS England, with no time for planning or communication of the role. People also wanted support for practicalities. As one trust said, something that people can take off the shelf rather than starting themselves. There's been so much work and time spent on all of these governance type issues in contract, but nothing was available initially. Many felt it was important that trusts learnt from each other, but commented that there aren't necessarily clear established forums for that sort of conversation to happen. So while it wasn't surprising to discover funding was mentioned as a critical external enabler, we also learned that as well as needing adequate sustained funding for the continuity of new roles, problems existed in practice with the alignment of funding and workforce planning cycles, and that short funding timescales could drive limited short-term thinking, and joint funding of posts created particular challenges for sustainability. Funding was also needed for backfill, for supervision and ongoing support of new roles, with money often covering only the training period of a role. Contracting in general was hampered by a lack of clarity about the purpose and value of new roles, with issues of capacity, capability, and caseload all being raised. So what's next for the research project? Well, in phase 3 of the research, we're undertaking 8 in-depth case studies across 4 trusts, covering community and inpatient services, and considering services provided to all age groups from the young to the old. And the aim here is to study teams on the ground to really understand how new roles are implemented and integrated in practice, and how this affects staff experience and care for patients and service users. And we've been able to recruit peer interviewers to interview service users and carers. The 8 in-depth case studies are looking at teams employing 8 specific new roles: the advanced clinical practitioner, physician associate, nursing associate, multi-professional accountable clinician, peer support worker, clinical associate in psychology, mental health and wellbeing practitioner, and education mental health practitioner. And we should also mention skill mix change and how this links in with boundary work. So in phases 1 and 2, participants described many examples of boundary work, which is understood as all the individual and collective efforts that people engage in to maintain or break down boundaries between roles or professions. And in phase 3, we're going to explore how this occurs in practice, covering 3 main types of boundary work. We'll explore competitive boundary work. So this is where boundaries between roles are hardened to differentiate one from the other. And this often involves people defending or contesting their boundaries. We'll also look at collaborative boundary work, where boundaries between roles are softened to emphasize similarities or common goals. And this type of boundary work often involves people negotiating or aligning to get tasks done. And finally, we'll also examine configurational boundary work, where managers and leaders might work to change the boundaries of existing and new roles. So this can involve managers establishing clear boundaries. So, for example, setting up job descriptions, operating procedures, governance for roles, or configuring a role to work with a particular client group. Or by contrast, it might involve managers softening boundaries. So that is doing all the relational work to help teams align and redistribute work between themselves. And we really look forward to sharing our findings with you on this aspect. So to sum up, our research suggests that better design, communication and integration of new roles in mental health has the potential to improve quality of care, build higher performing teams and improve staff retention. And our research is intended to inform everyone in mental health services by sharing what we've learned with staff, managers, service users and policymakers. So thank you for listening. Find out more about our research and our emergent findings over the coming months by going to our website. The link is in the video description, and any of our team members would be happy to answer your questions and tell you more about the project. And lastly, a huge thanks to our partners for working with us on this research too.